Jeremiah working in a basement? Does he even have a window? Got a 2x4 in back.
No, he's got a code name, Ghost Rider.
Camera stand from the 70s and a 2x4. It's congratulations.
Welcome everyone. You've now got to see the lovely underbelly of the Native Strong Town Hall before it starts. The fun things that we talk about, making fun of my office space. Welcome. Like I said, this is the, I believe, 29th week of our Native Strong Town Hall weekly presentation on the COVID-19 pandemic and the effect it's having on the Bemidji area, Wisconsin, the Native community, kind of all of the above. And as most of you know, or have tuned in before, it's an elevating or worsening, it seems, pandemic and issue that we keep on dealing with week in and week out. But thankfully we have our very own specialist, our expert, Dr. Lyle Ignace from the Gerald L. Ignace Indian Health Center here to help us out and kind of lead us along the way on how to best deal with this. For those of you who have joined us before, we welcome questions as we move along. So feel free to drop those into either the chat box if you are joining us via Zoom, or if you are joining us via Facebook Live, just drop a comment in and we will be moderating those as well. And speaking of moderating, we again also have our very good friend Mark Denning with us, joining us, and he will be, again, as I said, moderating with us along as we go, bringing his kind of connection to the community on a week-to-week basis. So again, thank you all for coming. And with that, Mark, thanks again for being with us. Take it away.
Winabuju Endwe Maganaduk, Nadwe Benezi, Indigenous Cause, Name Indodem, Anishinaabe, Indau, Neopit, Indonjaba. Originally from Neopit, Wisconsin, small town on Menominee Reservation, now living here in Waukesha. And when last we were together, a lot of history has transpired. We've gone through an election, and the results of which in community spread we'll be seeing shortly. We'll have some questions about that. And also, we have a lot of other social issues going on as well as COVID-19. I always kind of start this by saying, welcome to everyone that's with us here live. We have the privilege of having a computer. We have an ability to be able to see a signal that's live, and a lot of our relatives don't. If you have a question that you hear from someone, maybe they don't have access to a computer, they don't have access to Wi-Fi, they don't have access to a medical professional opinion or help, you're in the right place, because you can ask questions and represent for those folks. A reminder to all my friends and my good tribal neighbors out there, you guys, we have a chat box in our talk here. And if you move your cursor around a little bit, what will happen if you move that little arrow, or perhaps you have a hand, or it might be a dot. If you move that around a bit and move it to the bottom or side or top of the screen, you'll see some little icons appear. And one of those will be, it'll say chat. It's a little bubble, like a speaking bubble, cartoon bubble. Just hit that. And what'll appear on your screen is a note from our great own and other moderator there, Jeremiah, to everyone. He says, thank you for joining us, and questions are welcome. And he means that. In a lot of our shows, there's this idea that a lot of people call me up from different places on my phone to ask questions, which is great, but I'd much prefer it. And it's better if you ask here in this chat window, because then you can articulate the questions the way that you want, represent the ideas that you want to have represented. So please do so when you feel the need, or even right now, if there's something that that's on your mind and is pressing. This is a very important time in our history. There's a lot of information that's going on out there. So once again, Nottoway B'nai, my traditional name, Sturgeon Clan. And we've been doing this for, I believe, 21 weeks. Is that correct, guys? I believe 24, 14 weeks. He'll tell me when we go. So that was sign language, the Neopit sign language, so just some messing around, but it is a serious time, everyone. And thank you for being with us, because we're up against it and we need to know what to do and responsibly. So Dr. Ignace, we're going to give this over to you, and thank you for providing this opportunity for us to learn and learn from a responsible voice. So Dr. Ignace, if you would.
Right. Thanks, Mark, and thanks, Jeremiah. Week 29. Welcome back, and we've got all kinds of new things to talk about this week. New things have occurred, and under this current program, Operation Warp Speed, I've brought this up several times. We have 8 private biotech companies that are engaged in very specific types of vaccine. Most of what we've heard is Moderna and Pfizer in the headlines. We've heard about AstraZeneca. Very little known about Janssen, Novavax, and Sanofi. We've heard about Johnson & Johnson, a little bit about Merck, but all of these biotech companies have been well engaged. They're well into their 3rd phase trial. And I'm going to be talking about a couple of things that have occurred this past week, which are game changers in how we manage and how we look at preventing COVID-19 spread. So let's get to the very first item. And if we go to the next slide. So Eli Lilly. Now, this hasn't got as much attention as the vaccine, but the United States Food and Drug Administration, the FDA, has issued a emergency use authorization to permit the emergency use of a new drug. This new drug is very similar to Regeneron that was the president was given. And I'm going to be terrible at this name, but the name is bamlanivimab. That's a long name, but it is a monoclonal antibody, much similar to what Regeneron was. And this is actually used for the mild to moderate coronavirus disease, COVID-19, in adults and in pediatrics. So pediatrics being individuals 12 years of age and older. And this medication is not intended for inpatient use. And why this is so important is that it is intended for individuals that have mild to moderate symptoms of the virus. And why that's so important is that it may help reduce the hospitalization and certainly the fatalities measures that we are all following in the world. So this could have a very direct impact on on preventing individuals from going from mild to moderate to severe and hospitalized. Eli Lilly has made it very clear that this is not intended for use of people who are already in the hospital, who already have severe enough disease that needs they are already admitted to the hospital. So this is preventing people from actually having to go to the hospital. So this is a very big deal. And so the individuals that qualify for using this drug or receiving this drug are basically high-risk individuals. High-risk individuals who have confirmed positive with mild to moderate disease. And if they fit at least one of these following criteria, they are eligible to receive this. So people with body mass index, BMIs greater than 35, chronic kidney disease, diabetes, immunosuppressive diseases, or who are currently receiving immunosuppressive treatment, individuals over the age of 65, if younger than 65, individuals over the age of 55, and or have the following: so cardiovascular disease, hypertension, COPD, and the 12 to 17-year-olds. Okay, these are individuals that have a BMI 85th percentile for their age. So this is high-risk individuals, kids who are showing to be mild to moderate obesity, sickle cell disease, congenital or acquired heart disease, neurodevelopment disorders such as cerebral palsy, and individuals who are under mechanical or technical dependency. So that would be individuals who have a tracheostomy, a gastrostomy, which is a tube in the stomach to feed, or people who are on some type of positive pressure ventilation. So asthma, reactive airway disease, COPD. So these are all of the individuals that would benefit the most from this drug, who match any of these criteria, who have mild to moderate. So this is really looking at preventing people with these conditions and being admitted to the hospital, or preventing them from getting severe disease or worse, a fatal outcome. So this is really important, because up to this point, we have not created, not we like this program, but the world has not created an outpatient treatment. This would be a first of its kind. And what's different about this is it's not a pill. This is not in a pill form, it is an IV form. And it's a certain dose that you need to get. And it's a dose that requires you to go to a facility that that would be able to supply the IV and supply the medication. The medication runs over an hour, and then you need to be observed for an hour. So this is not a quick and easy. The safety profile is really good, and it's just a one-time dose. It's not a repeat dose over and over and over again. It's a one-time dose, IV. So for the individuals who fit any of these criteria, who become positive with COVID, who have maybe mild to moderate, but not severe enough to be admitted to the hospital, you would be a perfect candidate individual to receive this medication. And it can certainly help prevent you from being admitted to the hospital. So this is really big news that has come out in this past week. So the other big news that has come out is Pfizer. Everyone has heard about Pfizer. I've talked about Pfizer many of times. They have come out with a vaccine. Their vaccine, just to be technical, is an mRNA-based vaccine. It's a term BNT162b against SARS-CoV-2. It's a lot of initials. But they announced on November 8th that they have a vaccine after having gone through an independent data monitoring committee evaluation, that they have a vaccine that demonstrates 90% efficacy. 90%. That means COVID symptoms were prevented in 90% of participants who received the vaccine. That is really, really high. As a number, 90%, it's not absolute, but 9 times out of 10, basically putting it in those terms, 9 times out of 10, it says it will prevent people from getting COVID-19 symptoms. So this is pretty significant because historically, if you wanted to use a comparison, you could look at the annual flu vaccine. Now, flu vaccines, their effectiveness, their efficacy is not as high as this, what Pfizer is touting their vaccine to be. At best, it could work as good as 60, 65%. And then some years we've had it work anywhere from 30 to 35%. So there's definitely a range annually of the flu vaccine. Now, for Pfizer to come out and say a vaccine is 90%, has a 90% efficacy rate, that is really remarkable. And now, this is in a controlled setting, of course, where everyone is monitored, everyone is screened, everyone is followed up, everyone has routine blood tests. And so it's important to realize that this is under the best controlled situation. Now, the effect of this vaccine under real world conditions where any other year we would, let's say, for example, we would give flu vaccine. You know, we give flu vaccine, we give it to people and they roll up their arms, get their shot, and they leave. And in 10 to 14 days, they can assume that they have some level of immunity to the flu. Now, under these conditions, under the clinical phase trial, everything is controlled. People aren't limited as to where they can go, but they're still requested to follow the same routine as everyone else. But they don't, these are the individuals that get tested on a regular basis, blood test screenings, routine screenings for any side effects. And so these are individuals that are watched like hawks. And so it's important to realize the efficacy rate of 90% is good in controlled settings. In reality, it may not be as effective as 90%, but that time will tell. Now, the CEO came out on Monday with this announcement saying that they could have up to 30 to 40 million doses available, 30 to 40 million doses available for the United States in short order. And so 30 to 40 million doses. Now, people have to realize this isn't a single dose like the flu. You get one shot and then 21 days later, you get a booster shot. So whatever total max dose is available to us, cut that in half to be able to supply the number of individuals. So let's say they do offer 40 million vaccines, 40 million doses. Only 20 million people in the US would be eligible in that first phase to receive this vaccine. So in italics here on the bottom, I just kind of highlighted some of the numbers that Pfizer has rolled out just to assure people that over 43,000 people have voluntarily enrolled in this clinical phase trial. The safety profiles have yet to finally come out and be collected totally. But up to this point, Pfizer has not reported any serious adverse events, which is on the upside. That's very good. So they came out and said that they will submit for EUA to the FDA, emergency use authorization, as soon as they can gather their complete profile on their safety profiles and submit. Now the paper said that they would submit the third week of November. Well, third week of November is Monday, November 16th. So that is only a couple days away. And if they are able to gather everything and all the documents to submit, this could very well end up in the FDA's hands as early as Monday, which would be really remarkable. Now, my sense here is that it'll take maybe a week or 2 weeks for the FDA to review all of its materials. And so, I've been talking about this vaccine and a biotech company coming out, but I think everyone has to realize that the reality of this showing up to everyone is going to be quite limited. The CDC has recommended that every state be prepared by November 15th. And this was an announcement they gave out a month ago. So my sense is they knew when this was coming, and they knew that states have to be prepared for this campaign of vaccinating people. So if you could go to the next slide. So who gets the vaccine? Now, I had brought this up before, and this is the profile or the phases by which people would fall into and who would be eligible to receive the vaccine first. So right now, phase 1 is broken out in 1A, 1B. Phase 1A is the priority go to the high-risk workers in healthcare facilities and first responders. As of today, that would include essentially like all major hospitals, all major health systems, outpatient centers, urgent care centers, first responders, people who have first contact with individuals that could present as having COVID. So let's say a facility like ourselves, we have outpatient, we see outpatient walk-ins on a regular basis. Our facility, since all of our health services do come in direct contact with individuals, would be eligible for the vaccine as part of phase 1A. Now, that's the priority. And before I came on to this town hall, I came from a meeting that indicated that the first round of vaccines are going to go to the essential health workers. These high-risk health service workers are going to be first to receive this vaccine. That's that first campaign. The second part will be to addressing and targeting the high-risk individuals that are susceptible to the infection, the virus, and have severe disease or death. And I've been, reporting out on a regular basis what that group actually is. So we're talking about individuals over the age of 65, cardiovascular disease, chronic kidney disease, diabetes, immunosuppressive cancer, transplant individuals 65 and older, COPD. So all of these chronic care conditions. Now, for folks that have been following this town hall, we know that individuals that are impacted the most aren't the young or 30, 40, 50s. We're talking about ages 65 and older who have obviously, as we all get older, we develop chronic conditions. But these are the individuals that are impacted the most, either by hospitalization or by succumbing to COVID. So these are the high-risk individuals that are going to be targeted, and it's going to be important to realize that as this vaccine starts rolling out, that going from phase 1A to 1B, phase 2 would be looking at the kind of the second tier of priority of individuals. And these are kind of the working well, maybe the 60 to 50 year olds. And as the first priorities are addressed, the second phase will go into effect, and this is at least allows more time for a company like Pfizer or other companies like Moderna or AstraZeneca to start creating enough vaccine to take on the more general public as overall. So first phase, high-risk individuals and chronic care condition people. Second phase, when would that start? We're probably looking at a phase 2, maybe as early as late March or April for phase 2, and then it would be rolling out to be available to everyone in the general public as this moves on. Now, one of the things that I read with Pfizer is that this is not recommended. The vaccine is not recommended for pediatrics. Pediatrics is anywhere from newborn to the age of 18 or 17, I should say. It sounds and looks like they do not have a big enough, large enough panel or a safety profile on pediatrics to recommend this age group to actually receive the vaccine. So the vaccine is not recommended unless you fit one of these criteria. It will not be available at this time. I suspect that'll start coming out as more enrolled volunteers, and this involves pediatric patients who volunteer to get the vaccine, when we start getting more and more information out on them and the safety profile. But for now, it is just for adults, adults who meet the phase 1A or phase 1B criteria. So, but that's this week. Obviously, next week, information could change. This is the high-risk profile as I went through. If we could go to the next slide, we'll get right into the numbers. So as of today, November 12th, almost 52 million cases worldwide. The number of fatalities, almost 1.3 million fatalities worldwide. Here in the United States, almost 10.2 million. We've tested 155 tests million tests have been completed. I bypassed the recovered, just so you know, for world and the United States, because it's becoming more and more unreliable. Most states aren't reporting out recovered, the status of being recovered. So I'm going to be probably taking that off from here on out. But in terms of fatalities here in the United States, almost 240,000. Wisconsin, 285,000 cases. In Wisconsin, we have a much better way of tracking recovered individuals. That's 219,000. And the number of fatalities is 2,457. So as we look to Indian country, we know 573 federally recognized tribes in the country. There are an estimated 5.2 million American Indian Alaskan Natives in the country. Half of these individuals utilize the Indian Health Service. And we know that approximately 70% of American Indian Alaskan Natives live in more the urban setting. So if we could move into the numbers of IHS, one more. So let's get into the numbers reported out by the Indian Health Service as of November 10th. We see on the left-hand side, the Indian Health Service and all of the areas that make up the Indian Health Service. In the column of November 10th, the total is the total number of tests done to date. The next column, the segmented column, is total positive. That is the aggregated number of positives as of November 10th. Overall, 82,126. What I've been able to do, and the Indian Health Service doesn't track this out in this way, but what I've been able to report to you are weekly trends. Weekly trends, and we've dated this back all the way back to our first episode. So at least on a weekly basis, you get a sense of the activity of positive cases that are going on with respect to your area. Now, I've highlighted numbers that are in yellow, signifying that these are high comparative to the previous week. And so you get a better sense that the majority of the areas in Indian Health Service are very active. There are a lot of cases going on. Now, just because an area is not highlighted, it is usually has maybe plateaued for this week. But that plateau still signifies a high number. When you add them all up for November 10th, as of this week alone, there's been 7,804 confirmed native cases within the Indian Health Service. Now, last week we had 5,900. The week before that, 4,900. October 20th, 4,600, and so forth. So for a good month and a half now, Indian country has been deeply impacted. As the entire United States goes, so does the Indian communities. So what's an emergency situation, I feel, in all of these areas is that the numbers are not subsiding. There is nowhere in the country that Indian country has not been impacted. And you can imagine the concern and the angst that's going to be occurring in discussions that people will be having right now, because each one of us probably know someone who's either a family or a friend or a loved one that has been impacted by the virus, and all of our communities are feeling the stress of COVID right now. If we go to the far right, you see that the 7-day average positivity, this is a rolling 7-day average. So as of November 10th, you see that every area showing a pretty significant elevation. The positivity rates are high. I highlighted one. The Great Plains should be 24. That should be highlighted. That's above the average. So the concern here is that no one is, there is no hiding the fact that this is impacting every aspect, every corner of Indian country. Trends, they're up. They have been up. They've been up for a month and a half, 5 weeks. If we thought last week was remarkable with the 7,800 cases this week, that is really significant. And you can see as you go down the column, you can just see which areas are greatly impacted. And unfortunately, the Bemidji area, which we reside in, which Glick resides in, is part of that mix, along with the Great Plains and Oklahoma City. You see Navajo now has 857 cases this past week. They were in the news back in the midsummer as the main area in Indian country impacted by COVID. Well, we see that they're not the only ones. They're back to the level that they were in midsummer, along with Oklahoma City, Great Plains area, and the Bemidji area. So we are 4 big areas of Indian country that are deeply impacted by this virus. Next slide. Comparing Bemidji, Great Plains, and Billings to from the deep red, that's part of the Indian Health Service. Below that are health service websites for each respective state in their that represent the IHS area. Wisconsin, Minnesota, Michigan. We see the numbers are different. And when we collectively add them up, they're much different than what we're seeing in Indian Health Service. Now, most states require that all positive cases are reported to their respective states. I'm not sure if every single state does that, whether all tribes necessarily do that. But if you're tested in a federal facility, I can guarantee that your test results are being reported to the state. So there is a difference between IHS, and we know a great portion of individuals reside off of the reservation in urban settings. So now we have another data set as a comparison as to the activity that's going on. So in the Bemidji area, 7,300. This is 1,170 cases, 19% increase from the week prior, which there was only 827 reported. So even within this 1 week time, the number has greatly increased. When you look at the Great Plains, North Dakota, South Dakota, Nebraska, Iowa, 11,225. That outpaces IHS's numbers of 8,200. And so we now have a better sense of cases, and you could go through every state that represent every area of IHS and you would get this same pattern. There are more and more cases other than what IHS is reporting out. So it's important to realize if IHS says that we have 82,000 cases, you could probably multiply that, increase that by at least 70%, and you would get a better sense of the overall number of cases that are going on. So pretty significant, not just on reservations but off of the reservation as well. Next slide. If we look at the states within the region, we have Wisconsin, 285,000. We are far outpacing Michigan, Indiana, as well as Minnesota. Illinois has really accelerated in its cases. They're at over 500,000 cases right now. And you can just get the sense that the daily average of cases they're just increasing in all 5 of these states. Wisconsin is only second to Illinois right now. So it's, we're not just making note that our activity is a hot spot in the country right now. If we look at, next slide, we look at the Bemidji, and that's Michigan, Wisconsin, Minnesota. We look at this is IHS reporting out their incidence of COVID-19. We see right now that the national positivity rate is 9.3. If we look at the state of Michigan, 11.5, which is up 2%. In Wisconsin, it's nearly 36%, up almost 5% in the past week. And then Minnesota with a state positivity rate of almost 14%, and that's up 3 points over the past week. So, what we thought what maybe people in different states thought, well, this is maybe just a Wisconsin hotspot issue and concern. Well, as Wisconsin has gone up, it seems to be pulling Michigan and Minnesota in the same direction. So while we may be in this high positivity rate, Michigan and Minnesota may be just 2 to 3 weeks behind Wisconsin. So they could be seeing the same type of level of activity that we are in short order. So some places are definitely impacted more than the others. When we start looking at cases, incident cases by county, there's 3,141 counties throughout the country. If we look at each state, we see that Michigan, there are 3 counties that are the highest in the country. You see them here on the board. We have Baraga County. That's a hot spot. Keweenaw Tribe, that is their respective county. So you now get a better sense, tracking counties, how this impacts tribes. Here in Wisconsin, Menominee County, number 30th in the country. That directly impacts Menominee. So we've seen Menominee as one of the top hotspots as by county in the country. This is probably the 3rd week now that Menominee County has been ranked this high in the country. Looking at Minnesota, their number 1 hotspot county is Mille Lacs. Obviously, that directly impacts the tribe, and you can see their incidence rates and how they compare in each state. Indian country is a hotspot. Specifically, these 3 tribes, are in that top tier, the top 1%, 2% of counties in the country that are directly impacted by this virus. So let's look at respective states. So here we have the 12 states, the 12 tribes of Michigan. I followed the tribes by their county activity. So as you go from left to right, you see a point in time what their activity has been. So you see November 11th highlighted in yellow. You move a couple columns over to past change. You see that November 11th, the second yellow column, you see what the number of cases by county that are going on. So I mentioned that Keweenaw is way up north in the peninsula. I mentioned that this county, Baraga, is ranked 183 in the country. So you can see this reaches every corner of the country, and Baraga County, Keweenaw tribe is definitely directly impacted. You can see on the far right-hand side that the trends in all of these counties in Michigan are going up, with some that have remained kind of flat, but overall the upward trend is directly impacting all the tribes. In Michigan, we have 1,187 cases to date. That's 198 new cases in the past week. It's a 20% increase from the week prior. Looking at the rate of natives in Michigan, we see that it's nearly, for Michigan, it's nearly 2% of the estimated population have now been affected by a confirmed case of COVID. We look at the state of Minnesota. We have the 11 tribes in Minnesota. And as you can see, tracking left to right, you see points in time, the number of cases to date, and then the second yellow column, you see the number of new cases in the past 7 days. So as we go through the states, we see a lot of upward surging cases. We see some areas that are relatively flat, but for the most part, most of the counties by where the tribes reside in are increasing in their trending. 1,700 cases to date. That's 285 new cases in the past week. This is the highest number of native cases in Minnesota that's been recorded to date. 20.1% increase from the week prior, and a 2.2% estimation of natives in Minnesota that have gotten the coronavirus. Pulling it back to Wisconsin, the 11 tribes here in Wisconsin, their respective counties. Again, we look at it points in time. And the second yellow column, we see the number of new cases in the past week. Every county represented for each respective tribe, we see an upward trend in every single county. I mentioned there was 3,781 cases to date. That's 586 new cases in the past 7 days, an 18.3% increase from the week prior. And looking at the overall estimate to the native population of Wisconsin, we're looking at 7.3% of natives in Wisconsin have now contracted the coronavirus. So, as I mentioned before, Wisconsin is one of the leading states in the country for rates of cases. We see when we start looking more in detail as to what's going on in Wisconsin. Next slide. We see that the tribes, and when we look specifically at the incidence rates per 100,000, we see in the dark blue, which is the Fox Valley in the northeast part of the state, we have direct impacts to Stockbridge, Menominee, Oneida, Saucogin, and Forest County, Potawatomi. As the incidence rates go down, so does the shade of blue. So you see it lightening as the blue is lightening as you go more and more into the rural parts of Wisconsin. The next group I'm really concerned about is Lac du Flambeau, Bad River, and Red Cliff as maybe a second round of a hotspot here in the state of Wisconsin. So directly impact, I had mentioned Menominee County here in Wisconsin, the 30th county in the country with the highest incidence rates per 100,000. So a lot of activity going on in Wisconsin, without a doubt. I've included a heat map, again, just highlighting the areas that have the highest cases per 100,000. As you can see, Wisconsin's very well highlighted with really a beet red signature of activity, and that area, those areas of red outlines the Fox Valley as well as the northeast portion of the state. If we go looking at the state compared to other states, in terms of cases per 100,000, North Dakota is number 1, South Dakota number 2, Wisconsin, believe it or not, has gone down 2 spots. It was number 3, it's moved down to number 5. However, Minnesota's gone up by 2 states and now number 8 in the country, and Michigan number 20. I added a couple other tables here, November 4th, November 11th. This represents the activity of cases in the past 7 days. So you can see on any given day where Wisconsin ranks compared to others. So in the past 7 days, the only states that have had more numbers than Wisconsin have been Illinois and Texas. And I had mentioned Illinois had literally just taken off, and that's occurred in this past week. So they've almost doubled the number of cases this week alone than they had the week prior, which is really remarkable. So Illinois, Texas, Wisconsin, California. Number 5 in total number of cases is Michigan, Ohio, Florida, Minnesota. So Bemidji area is Wisconsin, Michigan, and Minnesota. And if you wanted to include Illinois, you could with Chicago with an urban Indian health center there. You could see Bemidji area is getting hammered with new cases right now. Pulling back to the state of Wisconsin, as I mentioned, 3,781. There's been one new fatality in the past week, so a lot of cases, but only one new fatality. And this is really working out to maybe averaging out to about one individual per week that in terms of fatality for this virus. Looking at the age demographics. So I cleaned this up a little bit just to make it easier to look at. So on the left-hand side, we have bar graph. We have the age distribution is peeled out here. We have the rates of accumulated corona cases by age group. And then as we go to the number table here, we see September 9th. And as you go, these are number of cases in the past week. So every week that I report out, I give you the number of new cases by that age group. And so as you go from left to right, you can see that the numbers just keep going up in every age group. And it has consistently done that for every age group. So back in September, we were talking about 20-year-olds, young adults, 10 to 19, teenagers, as well as 20-year-olds. And, it was quite obvious. You could say, well, this is the majority of all cases that are going on. But as time has gone by, we still see that, yes, 20-year-olds are still making up a good majority, but falling right behind them are the 30-year-olds, 40-year-olds, 50-year-olds, okay? So it is, the rates of infection every week are getting pretty even in these age groups. And then we also see that the young teenagers, as well as pediatric 0 to 9-year-olds, yes, there are cases there, but not to the extent that we're seeing in the older age group. So pretty significant distribution here. For Wisconsin, as of yesterday, Jeremiah had mentioned that we've had some record-breaking days. And in this past week, it seems like almost every day has been record-breaking because we've been over 7,000. And right before coming on to this town hall, we almost hit 7,500 cases. So we thought, yesterday over 7,000, but this is a new record for the state of Wisconsin, 7,500 cases in one day. That positivity rate is definitely going up. And we're probably looking at, I know this says 5,984 cases per day, but after today, this will definitely go over 6,000. So a much different outlook than what we were seeing even 2 months ago. We were talking something very different than what we are now. Looking at the state of Milwaukee, looking at Milwaukee County, they've updated their website, so I've taken the liberty to be able to show you a new dashboard that they have. So if we look at what I've done here is I downsized this to the activity that's been going on in the last 7 days. So if we look at the center map, we see that it's a heat map indicating, let's say the white areas being lowest number of cases, and the bright red, deep red, signifying the higher portion of cases. Now, we see, if you split this heat map in half, it's essentially the highway that splits north side of Milwaukee as well as the south side. So if we look at right at the center, right where Milwaukee, the word lettering Milwaukee starts, that that district area. That district area alone has almost 1,500 cases in that red area, that red region. And you can see as it fans out, we start getting into other areas that are beet red as well. The area that's up further north near the village of Brown Deer, that has 1,200 cases. So not every area of the state is or the county is impacted the same. We just know, looking at the tracking of cases, that the majority of activity is smack dab in the middle of where our urban clinic is. So as we kind of go around the horn, we see the number of cases, 3,600 cases in the past week, 74 hospitalizations, and 33 fatalities. As we look through the boxes right below the 7-day hospitalization, we get a better sense of where that hospitalization is occurring. We don't see a lot of hospitalizations in the younger teenagers, 20, 30, 40, even the 50-year-olds, very few cases. But as soon as we hit at 60-year-old or higher, then we start leaping into a different category. And that's where most of these hospitalizations occur. So this goes back to why phase 1A, phase 1B, high-risk individuals, 65 and older, you get a better sense of why the recommendations and priorities are going out to these age groups, because we see the hospitalization just dramatically goes up as we get into older age groups of 60 and older. Same with fatalities. We don't have any fatalities of 20 or younger. We have 130. The next one is 4. That's 60. And then we have 70, 11, 80-year-old and plus, 80 plus is 17. So again, we see more hospitalizations, 65 and older, fatalities, 65 and older. And so now we get given another justification as why we're looking at vaccinating 65 and older with chronic care conditions who are at risk not only of hospitalization, but also outcomes of fatality. So this vaccine, if given and shown to be as effective as Pfizer says it is, would have a absolute dramatic impact on its ability to reduce not only hospitalizations, but also fatalities. And now with Eli Lilly coming out with their monoclonal antibody, now we can start looking at this whole progression of COVID cases, of not only just going from asymptomatic, mild to moderate, treating people outpatient. Okay, we have inpatient treatments, but now we have the ability to reduce even high-risk individuals being admitted to the hospital, which will reduce fatalities. But now we have a vaccine. Vaccine will cut across every age group, except for pediatrics and younger. Every age group, not only reducing the incidence of infection, but also looking at cutting into and reducing this hospitalization, as well as the outcomes of fatality. So 2 huge therapeutic and vaccine interventions that have occurred this week. And this is actually pretty encouraging right now to see that at a time when we're seeing such high numbers throughout the country, that these 2 interventions are being introduced. Here in Milwaukee, we look at the rolling 7-day average of positive cases. So we know back in May and July, those were 2 points in time that were pretty significant. We started getting into late summer, September, yes, cases. Then we started getting into October. October was certainly bad. There was a point in time where there may have been an indication if we plateaued or start seeing some negative daily cases that maybe we will have hit our peak again. That did not happen, and it started rolling into now record-breaking days for the state as well as for Milwaukee. And now we're looking at almost 900 case per day average. And so different dynamic, much different dynamic now than they were even in the summertime. Summer doesn't even seem like, I know we in the news, summer was horrific and bad for everywhere. It's different. This is twice as much, almost 3 times as much activity as the summer has gone on. So much different dynamic. Positivity rates in Milwaukee County on the left, the city of Milwaukee on the right. They're pretty much coinciding with each other. As of the 9th, 19% positivity rate. The city of Milwaukee, 21% positivity. So definitely upswings, and you can almost mark it when this was going on. It's like mid-September, the activity started changing throughout the entire city and county. Looking at the 7-day average for the city of Milwaukee. Now, this is a little misleading as you look at this graph, because you'll see the orange bar, representing, May and July, and then you see mid-September starting to go up and up, and then you see the sudden downturn. Don't get misled by this. It's not that the activity has dramatically gone down. There is a delay. There's a delay in reporting between getting your test and reporting out on your test. It's about 72 hours right now, 3 to 4 days. So there is a delay. There is a delay in the number of cases that are actually being reported out. So that's why you see the dramatic drop. But as, let's say, this was reported out November 8th. So by today, end of day here, or even end of day tomorrow, this will change again, and it will be reflective of all of the tests over the past 5 days, probably like a big data dump. And you'll see that this curve will change again. Looking at the cases, that's good. The cases in Milwaukee County, the native cases now at 250, 33 new cases from the week prior, pretty significant jump. And I know that our agency has been part of, we've done a lot of testing, and I know we've reported out on a lot of cases, native cases. So I know we've been picking up new cases over the past week. So I know we are part of that aggregated data there. The next slide, I want to just take a minute or two to go through. It's a lot of information, but I just want to go straight to the yellow. This is highlighting data points November 4th to November 11th. And this is age group demographics for the state of Wisconsin, the number of cases, how many hospitalizations, ICU admissions, and fatalities by each age group. So you see on the left-hand side, the yellow represents the number of cases overall and the rates of hospitalization. So compare that to week, you see that the numbers, despite having a higher number of cases per week, we also see that the rates of hospitalization, ICU, and fatality rates are going down. I want to pay a little more attention to the right lower quadrant of this data set. So this breaks out more than just saying, we've had 42,000 cases this week. I want to know in more granular detail, who are these 42,000 people? So as we go down, we see it's broken out by age group, how many cases by age group, how many people in that age group were admitted, how many were admitted to the ICU, and how many fatalities. Now, if you just kind of quickly look at age groups 0 to 9, 10 to 19, 20-year-olds, 30-year-olds, yeah, there are definitely cases. 40-year-olds could be put in this mix. 6,000, 7,000 cases very small numbers are being admitted to the hospital. And even looking at ICU admissions, that number is even smaller. And then we get to fatalities. There's been no fatalities in 0 to 19-year-old. The misaged grouped one individual, so I had to take that off the board and put it, I didn't put it, the state put it, so into an older age group. So we see 0 to 50-year-olds, that activity is not as great, but as soon as you start hitting the 60-year-old age group and higher, that dramatically changes. There are fewer cases in this age group, but they represent more hospitalizations, more ICU, and more fatalities as the other age groups. So again, you know, I mentioned this several times. We look at cases. It's not just knowing how many cases. It's really about age group and who's the most impacted by this. We know that chronic care conditions, 65 and older. Now with Eli Lilly, with the medication, just think of these 42,000 people who developed mild to moderate symptoms. If they were eligible to meet the criteria to get that monoclonal antibody, you can imagine the hospitalization rate may, and this is just kind of quick spitballing, but the hospitalization rate could maybe dramatically be cut in half. So we have all these cases, mild to moderate symptoms, you can become positive, you get the monoclonal antibody, and that could dramatically reduce admissions to the hospital. ICU admissions could dramatically increase and maybe cut by half. And maybe even the fatalities could be cut in half as well. So just that drug, one drug alone could have such a dramatic impact. And we're just looking at this profile of 1 week in Wisconsin, and this isn't accounting for the entire United States, but Eli Lilly with this medication could have a huge, huge, huge impact on these metrics. Now add in the vaccine. Now we're looking at a prevention of getting COVID. So we have this full cascade of therapeutics and intervention. We have an outpatient IV medication. We have inpatient therapeutics. And on top of this, now we have a vaccine that could prevent infection. So now we're looking at prevention of corona. Could we be cutting this infection by half? So if we cut the infections by half, use Eli Lilly, cut another half, and so you see the cascading effect could be pretty dramatic across the board with this full scope of therapeutic interventions now. So huge game changer for the country. And along with the FDA, the CDC, NIH, as well as Operation Warp Speed collectively, it is quite remarkable what has been able to be achieved in the last 9 months, and to get to the point where we are, when we probably most desperately need therapeutic interventions and prevention vaccine, will this have a huge impact on the effect of this virus and life as we know it. So Mark, I'm going to turn this back over to you, and we have more time for any questions or comments.
Go back on with you, Dr. Ignace. So a couple things came in, and again, we got a chat box, you guys. So these two, one is kind of funny and not, and the other one is an interesting one. I have a question as well too. It's about, the first one is about vaccine.
Yeah.
So when we talk about vaccine, and by we, I mean the media or just people at the local gathering place or work area, there must be different types or sorts of vaccine, meaning, is this the vaccine that folks have been waiting for, meaning this is going to be for all people? Or is that a different sort of vaccine for COVID-19? Is this something that like you said, is just for folks that are assigned, meaning I go to Walmart or Walgreens or whatever. Jerome has a drugstore here in Muskego. I go there and the offer is, hey, we got vaccines for cold and flu season. And you can just kind of go there and pay out of pocket or just do it. So that's supposed to cover a certain different type of flus. So the question, this vaccine you're talking about, are there different types of vaccine? Specialty or a general thing? So just, I hope this is making sense.
No, I get it. And it's confusing because for individuals that may not be in the health field or understand the science, you know, and that's why I try to keep things as talking to everyone so they could understand. So there are four types of platforms, 4 different types of vaccines that are known to be effective to vaccinate people and cause prevention. Now, not every, let's say, the chickenpox vaccine versus the hepatitis B vaccine versus like influenza or the COVID vaccine. These are all different types of vaccines that cause prevention, but they may not all be of the same technology. They may use different technology to create different types of vaccine. But at the end of the day, it doesn't really matter what technology or mode of technology is being used if the result is that they are shown to be effective. Now, from what I can kind of glean from the participant's question was, you know, each one of these companies is going to come out with their own vaccine. Now, whether that is Pfizer or Moderna or AstraZeneca or Johnson & Johnson, they're all going to come out with their vaccine at some point. Now, we don't live in a monopoly society where only one drug company can only make the drug. We have a kind of a capitalistic system that allows biotech companies to develop their own vaccine. Every person in the world is going to, well, if available, can have a vaccine. The problem is not one biotech company can make that many doses. So we're talking about economies of scale, so we have to diversify. And if every biotech company takes a chunk of that and develops a vaccine, there could be different vaccines from different biotech companies that can do the very same thing. So, but because we're just getting out of the starting gate, Pfizer being number one out of the starting gate, they're going to be the one that will flood the market with their vaccine. Now, not every country is going to get this vaccine. The United States had entered into an early agreement with Pfizer to kind of get their first batch when they do develop their vaccine, and that's going to be 30 or 40 million doses right now. They have an option to buy more, which I feel will probably occur. But then by that time, Moderna will probably kick in, AstraZeneca will kick in, Johnson & Johnson will kick in. And so US has agreements with all of these companies to portion out, allotments, doses for their vaccine. So vaccines are going to be coming, whether it's Pfizer, all Pfizer, or maybe Moderna, maybe AstraZeneca at different parts of time moving forward in the next 6 months. If I get the Pfizer vaccine now, that's not to say Johnson & Johnson could have their vaccine out in public come spring, and they could very well have that by spring. And so, but at the end of the day, it may not matter what mode of technology of vaccine that we end up getting, as long as we know that it actually works.
To follow up to that question, is the vaccine, the length that it is, it works.
Mhm.
We've had discussions before about the limitations of vaccine, meaning there seems to be a end date for should someone get COVID-19. So let's say I get it, and then now I'm good for maybe 3 months, and maybe I'll reacquire it. So two questions are embedded in there. Is there science about the reacquisition of or getting it again, COVID-19, even though I've had it? How long? And is, if so, that I can get it again after a certain period of days or months? Is a vaccine then, does that have to be a renewable part of my health
Mhm.
regime going forward?
You know, I think so. A couple things. So we know the vaccine, first dose day 1, second dose booster day 21. Um, Papers, research that is coming out, not just here in the United States, but also in Europe, are indicating that yes, people, this immunity is much longer than what people, at least the initial researchers have come out saying it's only going to be around for like 3-6 months. There's now indication that this built-in immunity after contracting and recovering, that this immunity can last longer than just 3 months. Now, I will say there's going to be some caveats coming out with, you hear about people who've had it and then came back positive, within 6 months. I think we're going to hear some caveats to why that may be. Some stuff that's coming out very preliminary has not come out officially. This is really new, and it may take another 6-12 months before we actually know, why there are some people that have had it and then have gotten recovered and have gotten it again. There may be an explanation as to why that occurs, but right now there hasn't been a real good one. Now, Pfizer has come out that they feel that after getting the vaccine, that the immunity could last like a year. That's what Pfizer is saying. That's not, that shouldn't be a discouraging thing, because if you think about it, that would be pretty consistent with what we see with the influenza or the flu vaccine. We get it annually. We get it every 12 months. It's routine. It's part of our annual, checkups, or, our annual going to the doctor and getting a shot. So that it may very well end up being, we may be looking at a few years here of cycling through vaccines based on the genetic makeup of the coronavirus. Now to what it would maybe look like, much how we look at the flu and how we develop, research and develop and create a vaccine for the annual flu. We may be doing the very same thing with coronavirus as well. So there was one other point I wanted to make. So, one other thing that was noted about this virus is that they are not recommending it for individuals who've already had COVID. So these are, or naive, or I shouldn't say naive, people who've not had a confirmed coronavirus test. If you haven't had it, you would be eligible to receive it. They are not recommending individuals who've had coronavirus they are not recommending these individuals to get the vaccine.
So hearing that can be a bit concerning, because sometimes people will get COVID-19 and not know it. What is the concern behind, if you've had COVID-19, to not get it? Is it just that, oh, hey, you must be, there must be some immunity with you, so we want to get this out to people first? Or is there a compounding factor there that might be detrimental to someone who had COVID-19? And again, they didn't know it, never tested for it, but they did.
Yeah.
and somehow they get this shot unknowingly, and something's going to happen.
Well, I don't know if you can make those types of leaps. I think, because if you think about how that would work, to account for all the asymptomatic people, they would all need antibody testing. Okay, and that's just not practical. If we're looking at an urgent vaccine campaign nationally, worldwide, we know that blood tests, this type of blood test, would take, several days. It's not instantaneous. It will take, much like how we do the testing now, it takes 3 to 4 days. Well, antibody tests will take 3 to 4 days. So you can just imagine, not every lab is going to be set up to handle such a huge request for blood test antibody confirmation, or for positive or negative antibodies. We're talking about millions and millions of people. It's just not practical or even feasible to even go to that scale, especially if we're looking. So there's going to be cases where people who've been asymptomatic, who've gotten it, didn't know it, have positive antibodies, and will be eligible to get the vaccine, and they get it. And I'm not saying there's going to be any adverse reaction, but we don't know. I mean, I'm sure Pfizer did not enroll people who were asymptomatic, who have serum positive antibodies, and gave them the vaccine. I don't think that's part of their safety profile. So there may be times where we may hear something of this scenario that may occur. We just don't know. But I can't imagine that it would be detrimental to anybody, because this isn't like, the vaccine is not, you're not being introduced with the live vaccine. You're given the building blocks against the virus. You're not given the virus, okay? So that's also a big point of clarification. You're not being introduced. If you were to get the vaccine, you are not being introduced the live virus. So if you get it, you're not going to get corona. You may get side effects from the shot, but you're not getting the live coronavirus.
So Les, a couple quick things. We have a few minutes left, and that is, earlier you had talked about part of the factors in dealing with COVID-19 is body mass index, or BMI. The question was, is there a responsible website to do that? Because as we look at it, there's 4 different categories, right? There's normal, there's overweight, there's obese, and then there's extreme obesity. And so the question I got was, is there a category for Indians? It seems we tend to get t-shirts in the XL and XXL size. Right. So here's the thing. Can you direct people to a responsible site where they can get a real answer to a BMI question in their life, and as it kind of occurs to their health?
So the quick and easy way would be, the next time you go to your doctor, ask them what your body mass index, and how this is calculated is knowing what your height and your weight, and you can calculate your body mass index. Anything more than 25%, body mass index of 25 or greater, is considered to be obese. Anything greater than 30 is considered to be morbidly obese. So when you can Google this, and you can use any BMI calculator that's out there. And if you know your height and you know what your estimated weight would be, you can figure out what your BMI, it'll do it for you. And so, for a male, that is 6 foot, a BMI, your weight, for a BMI to be normal, you would have to weigh about 182 pounds or less to have considered a normal BMI. So If I weighed 190, I would be considered on the other side of that normal, but not by many pounds. So the BMI as they use in these criterias are not just being obese. We're talking morbidly obese. We're talking like 50, 60 pounds over your ideal body weight.
So any kind of input on and this would probably, and I've heard this in the weightlifting community, folks like Jeremiah out there who bodybuild and they put a lot of muscle mass on. Does that count against the BMI, or do they have to do their measurements differently? Because a lot of folks out there, including women, are still out there training with the time alone. They've really put a lot of emphasis on it, and that affects their weight compared to their BMI. Is fat equal to muscle in BMI considerations?
So there are other calculators that you could use that really take into body, body frame. We're talking body frame. Obviously, someone who is 6 foot and weighs 200 pounds and has, less than 5% body fat, you can't even pinch a centimeter of fat. I mean, just by evaluation that they don't, their number may be greater than 25, but obviously they're not obese. So we're really looking at body frame, and we're looking at the height and weight, and the general sense of someone who's 6 feet and 400 pounds and someone who's 6 feet 300 pounds or 200 pounds. You generally know who fits in what category and who would be at really high risk.
So I'm going to give this over, and I'm just going to do two things here and just kind of chime out. I'd like Jeremiah to weigh in here. We do have two questions. I want to be respectful and get to those. It means we're going to run over just a tad. I want to be respectful of your time too, Dr. Ignace, but they are important questions because they're watching. They're caring enough to ask those questions. So Jeremiah, if you might weigh in, and Dr. Ignace, in your concluding remarks, if you might give us some thoughts about that upcoming National Day of Mourning, or in other homes, Thanksgiving, and things that you may recommend for that day. So Jeremiah, the two questions for Dr. Ignace.
Yeah, actually, the one you kind of got to already was about the, whether or not if you had already had coronavirus, would you get the vaccine? And so you kind of answered that already. And the other one was regarding that Bamlanivimab, whatever, the new drug that's out. It makes me think of Ram Jam, the Black Betty song. But anyway, what have you heard about the supply of that, given the increasing number of cases? And then, with that, I'll leave you to have the final word as well. Thank you for all joining us.
Yeah, so right now, my understanding is the U.S. government entered into the contract with Eli Lilly to get 300,000 doses. 300,000 doses of the monoclonal antibody, with the option of commandeering 500,000 doses with an additional option. So now this is a new drug. It just came out, so there's going to be manufacturing back orders, and but to have 300,000 doses up front, you can just start looking at the areas. I think the general sense was the distribution would be to areas that are impacted the greatest. So essentially, you got to look at states that are hotspots, and Wisconsin definitely would be one of those hotspot states where we're kind of getting close to that line of hospitalizations. And so this drug obviously would have a high impact in hotspot states like Wisconsin, possibly even Illinois, or other regions of the country that are deeply impacted by cases. So, that is how they're looking at distribution right now.
Yeah, so that was the question that I had. You mentioned that the other one had already kind of been answered. So yeah, with that, like Mark said, Thanksgiving only a few weeks away. We do have our community harvest feast coming up in a week or two. So if you want to, leave us with your final words and maybe, remind people, how to be safe with the holidays coming up.
Yeah, so as people are probably aware and hearing over the news, Wisconsin is a hot spot. There are many other states that are surging in numbers. And what does that mean for you and your family? And, I think it's going to impact different people in different ways. And what I mean by that is a state like Wisconsin, where we're seeing over 7,000 cases a day versus, let's say, Montana or Idaho, where they're seeing maybe like 500 cases a day, just as a quick comparison. Obviously, Wisconsin much different in its transmission than Idaho would be. It doesn't absolve people from being cautious or the virus from being any less contagious than it is right now. It is and will continue to be that way. The impact, I think, in Wisconsin, looking at the holiday season coming up, is I think, and I had mentioned this a couple of weeks ago in a different podcast of, what does Thanksgiving look like? And I think what I mentioned at that time, I got kind of crooked looks because my advice at that time was to really reduce and limit the risk of transmission. I know people will be asymptomatic, and immediate household families I think are obviously much safer than introducing friends or distant relatives that don't live in your area and having them come over for this holiday season. I think is going to be very difficult. And with that, I would probably suggest to limit the contacts, especially around Thanksgiving and Christmas. And I know that's a downer because that's, for the most part, most of our families, when all of our families do get together and celebrate as in our own ways. But as a personal choice, we're always looking at risk to our old elders and individuals that we know that are high risk, not just from getting it, but also risk of hospitalization and a poor outcome, or even fatality or death as it relates to this. So people are going to have to be creative in how we move forward, and this may be looking at how do we do things virtually. I know that sounds pretty lame, but and we're not used to that. But I think right now, for looking at trying to bend the curve or minimize risk of transmission, especially to our elders, it's important that we do that, and it doesn't absolve us from wearing masks and social distancing, washing our hands, using hand sanitizer. We all need to continue to do that. So, but with what I presented today with Eli Lilly and Pfizer, these are two huge milestone therapeutic interventions and prevention drugs. And these are definitely game-changing interventions. And, several months ago, we were talking about, can we see the light at the end of the tunnel? Well, that end of the tunnel is getting brighter. And right now, with these two drugs being introduced into society, I think we are going to be able to have a much greater impact on the transmission and the prevention and the treatment of COVID-19 that could very well start seeing in short order, probably within 2 to 4 weeks after the first round of vaccine and therapeutic Eli Lilly being introduced. So there is light at the end of the tunnel. I know it can't, for some folks that feel like it can't come fast enough, but it is, and it will be available. And anybody who wants to have a vaccine will be able to get that, and obviously maybe be eligible for receiving the Eli Lilly drug. So 2 huge things, light at the end of the tunnel, as that's great. But right now, in the next 7 to 14 days, I think we're going to have to all be more attentive to our personal families and our surroundings until we can get to that point of receiving these vaccines. So until next time, everyone stay healthy, stay safe, and stay strong.